Hello everyone again. So I'm Mariangela Pellegrini. I work as patient program manager for the EURORDIS, so the European Reference Network on Rare Hematological Disease. So I'm very happy to welcome all of you. So this is the third session of a comprehensive program for patients and their family, focusing on aplastic anemia and PNH. I'm very proud to say that this program has been co-designed in collaboration with the Patient Representative and Patients Association. So I would like to thank my collaborators, so Maria Piggin representing PNH Support, and also Pascale Burmester representing Lichterzellen, and both of them PNH Global Alliance. Program really aims to disseminate topical area related to these two rare disease, or even very rare as for PNH, including like giving visibility to medical service available in Europe, quality of life, cutting edge advance in this field, and also treatment options. So we arrived to the point of today. So today we are going to talk about treatment of aplastic anemia. As for previous webinars, we have a duo of a physician and a patient representative. So today with us, I start with ladies. So we have as patient representative Jeanne, who is an actress. Hello, he's an actress and actor director. So she started acting at a young age and became a professional actress in 2004. And then in 2014, she received the Molière for the female revelation for her role in Le Cercle des Illusionnistes by Alexis Michalik, with whom also she created a new play in 2017, Intramuros. And she was diagnosed with bone marrow failure in 2015 and then transplanted in 2016. And with us as key physician expert of aplastic anemia, we have Professor Antonio Risitano, who is Director of Hematology and Hematopoietic Stem Cell Transplantation at the Hospital San Giuseppe Moscati in Avellino, and also Professor of Hematology at Federico II University of Naples. So, Antonio, I will
Good afternoon, everybody.
To you. Thank you.
So, I will use the next 25 minutes to discuss with you the treatment of aplastic anemia. Before that, I will spend a couple minutes just to remind everybody what aplastic anemia is, because if we better understand the biology and the disease, of course, it's much easier to understand why we are giving some specific treatments. These are my disclosures. You can see a list of companies that are working in the field, mostly companies developing anti-complement agents that are very active in the recent years, because we are changing the treatment of PNH, as well as companies developing some agents that are used for the treatment of aplastic anemia. And I would start from here. This is a kind of cartoon representing how our bone marrow should be. This is the bone that you can see on the top left side. And you see that all those pink stuff are cells, are hematopoietic stem cells. Basically, they are stem cells that are generating more mature cells. And these are the cells that you will find in our blood that are depicted at the bottom of the slides. You may have white cells, platelets, and red cells. And each cell type has a specific function in our body. And of course, if we miss these cells, we may have a problem. We may have fatigue and asthenia if we lack red blood cells, which means hemoglobin to bring oxygen around the body. Platelets are essential for prevent bleedings, and white cells are essential to prevent and to treat infections. Now, in aplastic anemia, we have something that is going to kill the stem cells, which are the one in blue. And well, if you kill the stem cells, in the end, you will remain without mature cells in the blood. And if you give a look to the figure on the top right side now, you see that the bone here is completely empty, which means that we lost all the blood cells which are coming out from the bone. So this is aplastic anemia, basically. We lack cells in the blood. We still have the fluid, but there is no cell or very few cells in the blood. And of course, we are exposed to many risks. So aplastic anemia is not just a single disease. You were alluding already to the terminology of bone marrow failure syndromes. These are different diseases that are eventually ending in the same clinical picture. We lack the cells from the blood, but there are many different diseases, and that could be related to different causes, because aplastic anemia could be associated with drugs, with treatment. Of course, we know that if we give chemotherapy, we decrease the number, we kill these cells. This is a kind of side effect for any chemotherapy. We know that viruses can do the same problem. And we also know that this condition could be somehow inherited, because we have children that may be born with bone marrow failure, or may develop very early in their life this aplastic anemia. So we cannot say that this is just one disease, but the vast majority is a disease where all these conditions are not present. So there is no, you are not starting from your birth with the disease. You don't have any virus, you don't have any exposure to drugs, to chemotherapy, or to any other drug. And this is what we call idiopathic multifactorial aplastic anemia, which in the end is an immune-mediated aplastic anemia, as I will discuss in a second. So we have two different players. The first one is the stem cells. The other one is the immune system. And it's just the balance between these two players that may eventually lead to the disease. So this is the same cartoon depicting the mature blood cells. Now, if you have some problem with your lymphocyte, your immune cells, you may develop some clonal T cells. These are not malignant cells, which they are supposed to kill bacteria and viruses. But if by chance they start killing hematopoietic stem cells, this is the consequence. You will develop aplastic anemia. So aplastic anemia, in the vast majority of cases, is an autoimmune disease caused by lymphocytes that are developing in your body. And the immune system is very complex. You see here that there are many different cells. Even within the lymphocyte, you may have B lymphocyte, T lymphocyte, natural killer cells. And well, we try to put order in the biology, but this is not very easy in the end. And eventually, we have to move from the biology to the clinic to better understand how the disease is causing cytopenia in our patient. And of course, we don't need to discuss the details of the cytokines which are produced by each individual cell type. These cells can kill the cell, these lymphocytes can kill the stem cells just binding to them in a very specific fashion, eventually leading to the generation of different cytokines, molecules, that are able to inhibit even the functioning of the stem cells. I will not provide any detail, but just I want to share this with you because ideally, these are all potential targets for treatment in an autoimmune disease. But let's move back to the clinic. Let's move to the clinic. Unfortunately, you are familiar with the disease, and Each time I speak to patient, I think very careful to what I have to say. This is a kind of survival car from the past, the very old past, because we are back to the 60s or to the 70s. And you can see that eventually these lines were going down quite deep, eventually meaning that the vast majority of patients were dying because of the disease. This is the past. And I wish to start with this just to tell you that in the past 50 years, some people, my mentors, our mentors, were able to really change the field, because now we have very effective treatment for aplastic anemia. And if this was the survival curve 50 years ago, I will show you in a second what is the situation now. And I would say not even now, because this was 15 years ago. And you see that 75% of patients are able to survive. And you see two different lines that depict the two different treatments that we may use for aplastic anemia: transplantation and immunosuppression. And just to anticipate what I'm going to share with you, of course, if we have a problem that our bone marrow is empty, we have two different strategies. The first one is that we bring new stem cells from a donor in that empty bone marrow, using also immunosuppressive treatment that may allow the engraftment of these cells. The other possibility is that we may start to treat the immune system, just killing, resetting the immune system, eventually hoping that some residual stem cells can lead to some recovery of the production of mature blood cells. I wish to share with you the next slide, which is depicting very old data, again back to the 70s. Oh, sorry, no. These are most recent data, very recent data. And you see that here the survival curves are approaching 100%, which means that we did huge step forward in the treatment of the disease. So there is more than a hope, that some hope for being cured from aplastic anemia. We can live with the disease, we can achieve almost normal survival, and this is using different treatment. You see on the left the immunosuppressive treatment, and on the right the bone marrow transplantation. But we will discuss this data more in detail later on. I just want to go back for a second, showing here something which is very important. See how survival was increasing over time. This is very important, but that means that day by year, we are able to improve the outcome of the treatment of aplastic anemia. And this is due to the huge work done by my mentor, by the collaborative work done all together, because this is the only way to advance the field, just doing clinical research together. And what is important here, if you see on the left side, we are able to give good life expectancy even to patients who are not responding very well to the treatment. So basically now we know how to live with the disease, and this is mostly because we have much better anti-infectious agents, antibacterial, antifungal agents that may help you to live with the disease. In most cases, we hope to live with the disease for the months that we need to get the hematological recovery. But even in patients who are not normalizing blood counts, we can still live many years with the disease. So I was used to present this slide at scientific meetings, but I took it for this talk today because honestly, for many years, we were very disappointed about the progress that we were making in the treatment of aplastic anemia. Eventually, we went very bad in the past 20 years. Well, let's say until 2020, we were able to improve the treatment in the 90s, but then the following 20 years were just nothing. We made many attempts, but we were unable to make any progress. This is something which is very important. This is the first trial. This is the first description back to the 70s, combining immunosuppressive treatment and transplantation. So we were trying, they were trying, I was not there. They were trying to treat aplastic anemia with bone marrow transplantation, and they were used to give immunosuppression before transplantation just to allow the engraftment of cells coming from a brother, from a sister, from a donor. And eventually that was successful, let's say in half of the patient. But at the same time, there was something strange. Patients who were not recovering with the same cells coming from the brother or from the sister were still able to increase the blood counts, which means that immunosuppression was able to treat the disease by itself without the help of any third-party stem cells. This was very important because basically this was the first evidence for the efficacy of immunosuppression in aplastic anemia. And here you see a cartoon showing the functioning of the lymphocyte of the immune system. And you can see that we may have different agents to target different steps in the immune system. Maybe the ones here are the most important because these are agents that are able to kill the lymphocytes. I was alluding before that you can even stop the cytokines, the molecules produced by the lymphocytes, or you can even affect the activation of the lymphocytes. But I mean, this is the portfolio of agents that we have in our pipeline, and eventually they were working very well. So I was telling you that for 20 years we were unable to do anything great. We were using ATG, which is a drug which is able to kill the lymphocytes, and cyclosporine, and we were trying to add androgens, no response, no improvement. We were trying to use high-dose steroids, no improvement. The standard of care was this one here, ATG and cyclosporine, because ATG was already used in the 80s, but when you add cyclosporine, you see that you increase the number of patients achieving partial or complete response, and you eventually prevent the relapse of the disease, because this is a treatment that you give for a few days. Then you have lymphocyte coming back from the bone marrow, and this lymphocyte can kill once again the stem cells, eventually leading to relapse of the disease. So this was the standard of care until a couple of years ago. We were trying to use different type of anti-thymocyte globulin, anti-lymphocyte globulin, horse ATG or rabbit ATG, but you can see that horse ATG remain the best treatment. You lose about 10% in terms of survival if you use rabbit ATG. And we were also trying to add additional agents, mostly targeting the lymphocyte activation or the cytokines. And all these attempts were really disappointing because we were unable to make any progress. Then we tried to do something else. Again, this was not something that was planned, because initially we have some compound which is named L-thrombopag that is able to stimulate the platelets. We were trying to use this compound just to increase a little bit the platelet counts in patients who were not responding to the treatment. Well, this was the initial hypothesis, and honestly, our friends were not very convinced about that. but the data were completely different, because when this compound was used alone in patients who have failed many lines of treatment, you can see the bone marrow here, how changed. So basically the bone marrow was empty before starting the treatment, and then it became full of blood cells, which means that this agent in about 40% of patients was able to increase blood cell production. So this drug was useful even as a monotherapy in aplastic anemia. And you see how this improvement was not only in platelets, but also in hemoglobin and neutrophil count. So based on this data, then we generated trials to investigate this treatment in addition to the standard treatment with ATG and cyclosporine. These are the data from the NIH. That was the first trial, phase 2 trial, using this treatment, L-Thrombopag on top of ATG and cyclosporine. And you see here that the proportion of patients achieving a response was as high as 80 or even 94% in blue. And more important, or as important, you see that about 30 to 50% of patients, green histograms, may achieve complete response. So the improvement is so good that patients may have normal blood counts, which is something very unusual in the context of ATG and cyclosporine alone. It's no more than 10% without L-Thrombopag. And indeed, this is the comparison. You can see that the rate of complete response was 58% versus 17%, sorry. And the rate of overall response was as high as 94 versus 66%. So this is just a comparison with an historical cohort. So at the same time, a little bit later in Europe, we decided to perform, this is the survival that I already showed you. And I was saying you that in Europe, we decided to do a formal comparison in a trial which is a phase 3 trial, randomized trial comparing standard treatment with ATG and cyclosporine alone versus cyclosporine, ATG plus L-Thrombopag. This study is named the RACE trial. This is the study design that maybe is not very important for this discussion today, but just see that the treatment is the standard one. The only difference is the addition of L-Thrombopag starting at day 14 from the beginning of the immunosuppressive regimen. And we were very ambitious in this study because we aim to see the change in complete response at 3 months. So the goal was to improve the quality of the response and the speed of the response. This study was recruiting patients in 6 different European countries. That was really a challenge, especially after Brexit, because we were shipping all bone marrow samples to UK for biological studies that I'm not going to discuss with you today. And we enrolled more than 200 patients. You see that there were about 40% of patients with a PNH clone, about 33% of patients with very severe aplastic anemia, and the age was very broad. We still have the majority of patients that were older than 40. Remember this cutoff of 40. And this was the success of this study, because we were able to see the increase in complete response at 3 months from 90.7% to 21% here in blue, and the difference in overall response rate was 31 versus 60%. So there was a huge difference between the 2 treatments. You can see over time how the 2 lines are different. Basically, the time to complete response is much shorter, is 9 months with the L-Thrombopag, and most of the patients do not achieve complete response without a thrombopag. The time to the first response, which means the first improvement, which means that the patient is not at risk of infection and bleeding anymore, is 9 months in the standard treatment versus 3 months, which is a huge benefit because basically you reduce the risk of mortality by 6 months. So this is very important. Of course, there were serious adverse events because infectious complication and bleedings remain a big problem for a patient with aplastic anemia, and we have to be very careful to treat this patient in the right way in our hospitals. And this benefit was kept in the long term. Very few patients required transplantation. Relapse rate was not very important, and many patients were able to discontinue cyclosporine. Of course, there was no difference in survival because we were able to rescue patients who were losing the response or were not responding. But if you look for the event-free survival, there is a huge difference because no more than 34% of patients with standard R may become alive without any event in the long term versus 46% in the L-thrombopag arm. Now, if you see the specific event, you see that the difference is even broader because in the standard R, basically all the failures, most of the failures were no response. So basically these patients were really failing the treatment. Now in the L-thrombopag group, many patients were relapsing, were reintroducing L-thrombopag. So basically these were just requiring further treatment, but they are still alive and they are still, I would say, quite good, and they have chance even for a second-line treatment if needed with transplantation. So based on this, we concluded that this should be the new standard of care for all patients diagnosed with aplastic anemia since the beginning of their treatment. There are some problems in Europe because the L-thrombopag is not yet approved as first line, but we are able to give to most of patients. This is true only for adult patients, because in children, things are completely different. There is no benefit with L-thrombopag, and the standard of care remains ATG and cyclosporine. And eventually, if you compare ATG and cyclosporine with the other treatment, which is a transplantation, in children, you really prefer to give transplantation. And this is what I'm going to discuss with you in the next few minutes of this talk. Because of course, the reason why we may prefer immunosuppressive treatment over transplantation is because transplantation is associated with potentially life-threatening complications like graft versus host disease. And of course, transplantation has some mortality. So we have to keep the right balance, and if not needed, we start with immunosuppression and then we move to transplantation. However, we should do this based on scientific evidence, and this is what I'm going to share with you right now. So first of all, see here how the treatment, the age impact the outcome of transplantation. Patients who are very young have a very good outcome. Expect survival is close to 90%. So this is from sibling donors, so patients who have a relative, a brother or a sister with HLA identical. In patients younger than 40, the survival rate is really good. So this is the reason why we offer transplantation as first-line treatment to patients younger than 40 if they have a sibling donor. The problem with transplantation is the risk of GVHD, and you can see that the risk increases over age, and this is the reason why in older patients we have to be very careful with giving transplantation, even because even the risk of reject is increasing in older patients. Now, if you use donors who are unrelated, so still HLA identical but unrelated, you see that the survival curve are a little bit worse, maybe not in children, but in patients who in the older than 20, I would say, and of course older than 40. And this is the reason why, if you make some comparison, basically we still prefer to give immunosuppression as first-line treatment in patients with the age between 20 and 40. Here are you see the data with 20, sorry, 0 to 20, and you see that here there is some the two curves are superimposable. So here the problem is that if you look for survival, they could be similar, but if you look for event-free survival, there is a huge advantage for transplantation because the risk of relapse is very high in patients receiving immunosuppressive regimen. So here there is a benefit for transplantation as first-line treatment. And even if you use unrelated transplantation, results are so good that it's very reasonable to offer unrelated transplantation upfront for children, which means patients younger than 20 with diagnosis of aplastic anemia. And you see here the difference in event-free survival if you compare transplantation with immunosuppressive regimen. Now, if you move to patients between 20 and 40, results are a little bit worse, and event-free survival is still better, but there is some mortality for transplantation, and that's the reason why you prefer to give transplantation only if you have a matched sibling donor. So if you have a matched sibling donor, you still start with transplantation. If you have an unrelated donor, you start with immunosuppression, and then you move to transplantation. If a patient is older than 40, unfortunately, results are worse with both immunosuppression and transplantation. However, the mortality of transplantation may be high, and that's the reason why you start with immunosuppression and you reserve transplantation only to patients who fail first-line immunosuppression. And basically, this brings to the final algorithm that I already discussed with you. In children, if there is a sibling donor, you start with transplantation, and only in some patients that may not have a donor, you may consider immunosuppression without a thrombopag, and if there is a failure here, then you move to transplantation. However, you see here this arrow claiming that you may have unrelated transplantation even upfront if you are able to find this donor very quickly, because of course timing is crucial in the treatment of aplastic anemia. So you have to start with the treatment. If you may have a good donor within a few weeks, you can wait. But if you have to wait for months to get a donor, you have to start with immunosuppressive treatment as soon as possible. If you are older than 20, if you have a donor, you still but if you are older than 20 but younger than 40, you still prefer transplantation as first-line treatment if you have a matched sibling donor, HLA matched sibling donor. If this is not the case, you start with immunosuppression plus a thrombopag. This is because this is the treatment that offers you the highest chance of survival and the highest chance of response. And then if you fail, you may eventually have unrelated transplantation or even haploidentical transplantation. Now, if you are older, or if you got, let's say, a late relapse, there is still a room for a second round of immunosuppression to keep the disease under control. And I think I will stop here. I just want to thank the people who made the RACE trial, just to highlight once again how important are collaborative studies and collaboration in general, not only between physician and investigators, but also between physician investigators, patient association. And this is exactly why we are very proud to have this European network that Mariangela introduced in the very beginning of this talk. So thanks for your attention, and I'm sure that there will be many questions to answer.
Thank you, Antonio. But I see there is no goalkeeper on the other side of the field.
No, you are right. No. Sorry, it's on the left side, the goalkeeper.
Only one. Ah, yes, sure.
We have a very good goalkeeper, and we have a very good striker that was Carlos. So, okay, but even the wings were not bad. So.
By the way, thank you for your presentation. Thank you very much. It was really clear. And I will leave the floor to Jeanne, and then also to other comments and questions. Thank you.
First of all, I want to thank you. Thank you very much, because it was very clear. And you already answered a lot of my question. And second, I want to apologize for my English, because it's pretty rusty and not very good. So Mariangela could translate if I if I need so. First of all, I want to ask you. I've been a transplant with a hematopoietic stem cell in 2015, and I'd like to ask you what's the difference now. Est-ce que tu peux traduire, Mariangela? Quelle est la grosse différence qu'il y a eu entre il y a juste 5 ans et enfin 7 ans et maintenant?
So she would like to know if in this kind of procedure, since this 5-7 years, there has been any big difference to be remarked on the stem cell transplantation.
Okay, I would say it depends from the donor. If you were transplanted by or with a sibling donor, which means a brother or a sister, eventually there was no change. We are still using the same procedure. I think this is more or less the same, even if we use an unrelated HLA matched donor. Things are completely different now in the field of haploidentical transplantation, because we are able to offer a quite safe transplant procedure even to patients who have just an haploidentical donor, which means that they are 50% identical and 50% diverse. So in the past, we were not used to give transplantation for aplastic anemia with this HLA incompatibility. Now we are able to give this transplantation with very good results because we are using a different prophylaxis for graft versus host disease, which is the use of cyclophosphamide, high-dose cyclophosphamide in the days after transplant instead of before transplantation. So that was a huge difference initially in leukemia, I would say 15 to 20 years ago. And day by day, we are transferring this change even in the field of bone marrow failure syndromes, including aplastic anemia.
Okay, thank you. And I have another question. I understand pretty well that RACE is an European organization. And how do you manage to work with so many different professors from around Europe?
Well, honestly, it was quite easy for me, and I would say for my friend Regis Peffot de la Tour, because we found a very well-established group, which is the European Bone Marrow Transplantation Society. And our masters back to the 70s and the 80s were starting transplantation. At the same time of transplantation, I alluded to those pioneers. They were pioneering transplantation as well as immunosuppressive treatment, and they have collected data for 50 years. And as young doctors, people like me and Regis were joining this group about, well, a couple of years ago. I would say now it's almost 20. No, it's 20. It's more than 20. And well, we had just to continue what they were doing, keeping this collaboration, keeping good personal relationships, and even friendships in some cases. And this is the only way to do good science together. Of course, sometimes you see there is always some competition. Eventually, we have some competition between Europe and US, but in the end, maybe because this is a rare disease, we still like to sit down together to compare our own data and to have the field advancing. So, of course, this was a huge challenge. I think we were very lucky because we saw some improvement in transplantation, and mostly the availability of new drugs stimulating the stem cells. I think it's great that right now we are able to keep these collaboration not only at the level of professionals, but also at the level of patient and patient association. If I can make a kind of nasty comment, I hope that our health systems will allow us to do this even in the future, because you know you need resources for that, and sometimes they are not enough, especially when you deal with the public health systems like in our own countries.
Okay, thank you. And are you sometimes talking in Europe about special case of patients?
Yes, we are used to do that, both at some meeting with patients as well as at our own scientific meeting. This is very important, and what we are trying to do within the EBMT, our society, is just to provide some opportunity to physicians to discuss these cases with experts for two reasons. The first one is that some people with better expertise may give very good advices to people who are not used with that specific condition. And the second one, even people that may claim to be experts may still deal with very strange cases. And we are used to talk, to speak each other, just to discuss what is the best for that specific patient. And this is the reason why I think we are very fortunate now, because we can do it by email, by TC, is much easier as compared to the 80s, 50 or 50 years ago.
Okay, thank you. And I'd like to ask you also, when you decide a treatment, so you explain it very well, but what are you still excuse me, Mariangela, help me. I'm sorry, I'm so sorry.
My English is not better, so don't worry.
Est-ce que il décide, j'ai bien compris qu'il décidait en fonction de l'âge, mais est-ce qu'il décide aussi en fonction de ce que ça va, des effets que ça peut avoir, par exemple la GVH, est-ce que c'est, enfin, est-ce qu'il décide, je suis désolée, even in French it's complicated for me. I'm so sorry. I have a newborn and I don't sleep a lot, so I'm very apologize. Non, savoir si quand il décide un traitement, when you decide for a treatment, if you decide, for example, for the transplant or a treatment, what the consideration of the side effects of a patient?
Well, of course, we have to keep a balance between the risk of side effects and the possible benefits. I would even extend your question, because this is something that I made very easy in my presentation, but this is something that we discuss with the patients and with their families. So it's very important the way how you inform the patient. You should be able to explain what the disease is, what are the risks of the disease, and how you can handle these risks. And then you deal with the therapeutic options. And of course, you have to create a very good relationship with the patient, because you have to make him or her aware of the situation before taking a decision. And of course, depending on what you say, it's very likely that you can push a patient to do transplant or immunosuppression. Because I mean, if you say to somebody, you will be cured by 100% with this treatment, of course, they will choose that specific treatment. So you have to give all the information in a very unbalanced way. And then you have to see the risk. Of course, my problem, honestly, when I discuss with the patient, my problem is not the risk of side effects. We know that we are dealing with a disease which may have many risks and many potentially even life-threatening complications. So, of course, we have first to decrease the risk of the complications, and then you see the benefit that you may have. In other words, the highest risk is always the disease itself, because without blood cells, without white blood cells, and without platelets, the risk of infection and bleeding is very, very high, very, very severe. So in that condition, of course, you need a treatment that may be effective as soon as possible. That's why you keep still transplantation even as a frontline treatment in very young patients, because if you have no extra risk due to the procedure, or that risk is acceptable, you can keep that risk. We know that in children, the rate of graft versus host disease is no more than 20–25%, and eventually it does not affect survival, because for some reason even the treatment of GVHD is more effective in younger patients. And that's why with the survival expectation higher than 80 or even 90%, we give transplantation, because the risk of infectious and of bleeding is much higher than 10–20%. And that's why it makes a lot of sense starting with that. Of course, now we have a treatment which is non-transplant based, is resulting in a very good response rate. We are changing a little bit the scenario, because in some patients now, you don't want to wait weeks for the transplantation, because you are still at risk within those 4 or 6 weeks waiting for the transplantation. So you say, okay, I start some treatment, and then if I didn't get any response at 3 months, I can move from from immunosuppression to transplantation. So of course we keep in very high consideration all the risks, not just the side effects, because side effects is something that you will have to deal with. I mean, side effects of any treatment, steroids, hospitalization is a side effect by itself, because you have to stay in the hospital. You have to take medication for preventing infectious diseases, and this may have side effects. So these small side effects, I think is something that we have to accept. What is important is reducing the risk of events that cannot be recovered. So all the ones who can be fatal, or the ones who may really affect the patient forever.
Okay. And do you...
Sorry, I just wanted to ask a question that was written in the chat before time is over. Somebody asked that in one of your last slides, there was a diagram about the transformation of aplastic anemia, I think in AML, and I don't know, something else. And the question is, why did you not mention PNH in that? Okay, because PNH is not a cancer, and you can live with PNH without many troubles in some way, especially with the new treatment. Whereas leukemia is a cancer, the survival of leukemia is much worse. So this is a condition which is even more aggressive than aplastic anemia. So we know that about 10% of patients in the long term, which means 10 to 20 years, may develop a myeloid cancer, a blood cancer. Aplastic anemia is not a cancer, but those patients developing cancer then require the same treatment that you need for leukemia. And this is very challenging, especially if you recognize quite late in the disease course. PNH, even if you develop PNH, you still have very good treatment, and you can live with PNH, I would say, forever. The survival of PNH right now is equivalent to that of patients of the same age. So life expectancy is not affected by PNH. It's a different disease. There are very effective treatment, and is not the most feared complication of aplastic anemia. Okay, so you didn't mention it in that slide because it doesn't affect the treatment of the aplastic anemia. Yes, right. Mm-hmm. Thank you. You're welcome. Jeanne, keep going.
Yeah, I have another question. Do you think a patient needs to know everything about the different scenarios and...
That's a great question, and honestly, I have no answer. I was so lucky to work in different countries, even in the US, so I know that the expectations are completely different, and in some way you have to follow patient expectations even in the way how you inform them. Mm-hmm. I do believe that they have to receive all the information, but the way how you do it is completely different. But I don't think they have to know the details. And of course, not all of them may really understand the details because of some social or cultural barriers. But you have to do the best to make the patient aware of the situation. And then, of course, you don't need to pretend a therapeutic decision from them. So you give the information, and eventually I'm used to say, look, we believe that this is the best treatment for you because of this, and this. So I try to explain and to let the patient follow me in my daily activities, because it's important that they are informed, especially because they can help us to identify and to intercept clinically meaningful events like infectious complication. Imagine a patient who doesn't go to the hospital with some infection, and then of course you have to deal with the different health systems. Sometimes patients go to the ER, sometimes well, in Italy sometimes they call you on your private phone just to inform that they have fever, and you can give some early treatment that could be really life-changing in some specific conditions.
Okay, thank you. And do you have patients who wants to I don't know, want to share their wishes for the treatments? I mean, do you have people who wants to comment on peut, excuse-moi, Maria-Angela.
I understand.
Okay.
Yes, I mean, yeah, I mean, you sometimes you have patients that could be, that want to be, let's say, the protagonist, the first player, even in the treatment decision. Of course, this is possible. Of course, we give them all the instruments to get the right decision, because in the end, the decision is always taken together. But we are used to say, and I hope to not to offend anybody, that the worst patient are physicians. Because when you have to deal with physicians, and of course they pretend to have all the instruments, sometimes you are unsuccessful to explain them the situation. So I still believe that it's very important that the expert physician drives not the therapeutic decision, drives everything, the management of the patient, together with the patient and his own family.
Okay, thank you.
And here was another question in the chat. Do you have any data on late relapse of aplastic anemia, like after 10 or 20 years?
If you mean after a thrombopag, not yet, because this study was started a few years ago. Yes, we know that the rate of relapse in general is around 30 to 40%. Apparently, this is not different with the thrombopag based on US data. We are just looking for this. And what is important is that the rate of relapse is higher in the initial months after treatment discontinuation. So more or less, as in leukemia, so you continue cyclosporine for at least 2 years in aplastic anemia. So the 2 years after cyclosporine discontinuation are the ones which are crucial for the relapse, and possibly even the second year where you start tapering cyclosporine. Now, indeed, we have a kind of condition which is called cyclosporine-dependent response. You are unable to discontinue the cyclosporine. We don't know whether this will be the same with the thrombopag, because now we know that some patients are receiving a thrombopag not just for the 6 months initially planned, but even for years, just to keep blood counts good enough.
Is there, by the way, is there any recommendation how to taper cyclosporine?
Yeah, for cyclosporine, the recommendation is that you keep at the full dose for 12 months, and then you taper to 0 within the next 12 months.
Mm-hmm.
So let's say more or less is 10% every month.
Thank you.
Can I ask a question, please? Antonio, I'm interested in L-Trombopag as a first line therapy. How far away are we from that being standard of care? Because I know in the UK where I'm based, it's not available.
Okay, Maria, thanks for this question. We are far away because the companies and basically the company asked for this a couple of years ago before that race data were available, and they didn't succeed. Now they are not going to resubmit the application. So what we have discussed, yes, this is, I mean, there is also an issue with patent expiration. So they are not interested, despite we were trying to push them. So we had a very tough discussion within the European bone marrow transplantation group. And the final decision is that we are approaching our national authorities country by country. So some people in UK will try to approach your health system, trying to have a kind of special access. I think that this is easier in France, possibly in Italy, but we want to provide some help for all European countries, because we believe this is a gap for now, and we have to fill this gap as soon as possible. Let me also comment that we have the same situation with ATGAM, with ATG, because also ATG is not approved in European countries except Slovenia. Now the company is working on it, and that will be approved by the end of the year, I would say, in most European countries. But this is a problem, and this is a problem which is quite frequent with rare disease, with orphan drugs, and there is a full commitment of the Severe Aplastic Anemia Working Party to solve this problem as soon as possible.
Can I ask a follow-up question? If L-Trombopag, as you have demonstrated with your slides and the evidence, is such a breakthrough for aplastic anemia in terms of treatment and efficacy, why would the company not be interested in taking it forward? Is it about price?
It's because the patent is expiring.
And what's they can just apply for another one?
No, because you will have biosimilars, so some other companies will take the benefit. This is a kind of financial strategy that I don't like to comment, because it's really disappointing. I fully agree with you. So
are there biosimilars being made for L-Trombopag?
Yes.
Well, that's good news, I think, isn't it?
Yes, of course. Yes, of course. There are some other drugs which are not biosimilar, because they are doing the same development, as well as biosimilars. So eventually, I think this will allow a broader use of these compounds in the next few years. But it's still disappointing that, you know, the official one that has been investigated is not approved. And it's a pity that it's impossible to approach EMA at the European level, because even if we do it, then we have to do country by country. So just in the interest of time, we try to do something in each country. But again, maybe this is something that we can discuss within the EuroBloodNet, even with patient association, because I think patients should raise their hands to claim that it's very important to have the access to this drug as frontline treatment.
Thank you.
Elena raised her hand. You have a question, Elena?
You are on mute, Elena. Ciao, Elena.
Yes, Mia, ciao. I'm sorry, I lost a connection for some time, but I don't know if the question was raised also. It's about the L-Trombopag. And in fact, for how long do you keep it, the longest that you keep it? I know it's for 6 months, but do you have any patients that you keep it with low dose, something like 50 milligrams for long term and with no issues, or you never do that? Because it's a patient that it's about 18 years old. She responded very well with Eltrombopag, but as soon as I tried to take out Eltrombopag, platelet counts were lower, white blood cells are a little bit lower, and as soon as she got back to Eltrombopag, she increased, but she's more than 2 years now on Eltrombopag, and I'm a little bit concerned about that.
Thanks, Elena. I was alluding to this a few minutes ago. Initially, we were treating patients just for 6 months, but now we have patients who are receiving the drug since, I would say, many years.
Okay.
Okay, we may say without major concerns. I would prefer to say that they didn't experience any problem, but of course, this does not entirely rule out possible concerns about not the long-term treatment, but the evolution of the disease. So while I would say, if needed, I don't see any reason to stop the treatment. I agree with that. I would say that this also depends on the specific patient, because long-term treatment with Eltrombopag is still a kind of treatment failure, which in a young patient could be an indication for a second-line treatment, including transplantation. For some old patient, I have no problem. I have patients who are in their 70s or even 80s that are receiving the drug since years, and I'm fine. In younger patients, I'm not so sure, so I would try to stop. I would try to be a little bit flexible with the numbers. In other words, I would prefer to have 70,000 platelets without Eltrombopag instead of 200,000 with Eltrombopag. But if you need treatment because patient is at risk of complication, you have to give.
Okay, and something, thank you for this. And something else, do you follow them if you have long-term Eltrombopag? Do you think there's a reason to follow them with NGS?
No.
Okay, thanks.
We followed them with bone marrow analysis, biopsy and aspiration, but based on the data that we published, NGS is not adding very much information. Just a few genes can really predict the long-term outcome, but the vast majority are just neutral and they do not impact the outcome. We are doing it just for scientific purpose at the moment, and the King's College group will publish some additional data in the next few months.
Okay, perfect. Thank you, Antonio.
You're welcome.
Are there any other questions from patients or anyone who hasn't had a chance to ask their question today? I know we're running a little bit over time.
We are bombarding you, Antonio, with questions.
And remember, no questions is a stupid question. Just ask.
It may be very stupid sometimes. I fully
So there is a new one. Are there centers of excellence to treat aplastic anemia in Europe? In Canada, almost every hematologist deals with aplastic. I can answer to that.
Yes, yes. I was just saying that. Yes, there are many centers. They are spread in all European countries, so as well as Canada and US. So some of them are in this EuroBloodNet, and there are many experts in different countries that may treat you according to the international guidelines. It's a rare disease, but is very well acknowledged in the field of hematology.
Yes. And thank you. And if you want to see the reference center in Europe for aplastic anemia, I can advise you to go on our website, so EuroBloodNet.eu, and you have a search engine that you can filter by disease or subtype of disease, and you have the list of all the expert center and physicians or multidisciplinary team in Europe. Okay, so, well, we arrived at the thanking part. So really, I would first thank Jeanne, because I know it has been hard preparation for this webinar. So thank you very much for having shared your thoughts. And also, I've really appreciated your point on really public healthcare other than reflection on the specific disease, because it's really useful also to understand and know how to navigate those issues. So thank you very much. Sometimes we forgot about it. Thank you. And then Antonio, also thank you very much again for explaining to us all those information in a very clear way. And also to my co-coordinator of the program, Maria Pascale, for putting together all these. And thank you very much.
Thank you very much, Mariangela, and thank you to everybody for listening.
Thank
you.
you.
Thank you.
Have a nice evening. Bye-bye.
Bye.